So comparing psychiatry to pretty much all other medical specialties, and using the examples we just mentioned, right? So the elevated blood glucose is not the cause of diabetes, but is the diabetes per se. It's a closer look at the phenomena that allows to distinguish from other possible causes of dark discoloration around the neck. I think it's called acanthosis nigricans or something like that. So you see, the blood sugar being elevated is the diabetes per se. Of course, diabetes is the name of the syndrome, but you can call that the cause because that is the problem itself, right? So we will have to look for causes when it comes to, I don't know, genetics or something else. But the whole point is to say that other medical areas have a closer look into the biology and markers of their diagnosis. Now, and there's another example. Okay, the COVID virus is the cause of the symptoms, but not the only determinant of the whole syndromic presentation. As some people have no symptoms while others need ICU care. So then the medical world keeps looking closer to find what those determinants are. And they spoke about all kinds of things and levels of vitamin D and age, blah, 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 right? So psychiatry has none of those. We go from symptoms to the final diagnosis. There's no closer look, no biomarkers. We don't know the causes. Of course, you cannot have PTSD without a trauma, but having a trauma doesn't give you PTSD necessarily, right? And then people say, oh, how about functional brain imaging? That, there's a lot of very nice advances in that field. But the problem with the findings at this point, at this moment where we are, and the same for every neurobiological studies, is that they're not specific enough, which shouldn't surprise us if we consider how much overlap there are between all disorders, right? Or syndromes. Serotonin levels are also not specific from depression. They're a correlate of all kinds of things, dominance behavior, aggressiveness, etc. So because other specialties have this privilege of actually looking closer to the syndrome itself, and we don't, they have a much higher rate of agreement when it comes to diagnosis, right? You give the same patient to 10 different doctors, and likelihood is, at least, I don't know, most of them will reach the same diagnostic conclusion. Now, when it comes to psychiatry, we have a very low inter-rater reliability rates, which is to say, and the way we measure that is like you take two patients with a known diagnosis of schizophrenia, for example, and or different. You take like 10 patients with a known diagnosis of schizophrenia and you give them to be assessed by two psychiatrists independently using standardized semi-structured interviews. And their rate of agreement and hit on the right, like how many of those 10 will be diagnosed with schizophrenia by both of them, and you'll be surprised that the numbers are like 3 of the 10, 2 of the 10, 4 of the 10 at best, right? So and that makes safe to say that psychiatry is pretty much the last developed field of medicine. Here's another problem with the syndromic diagnosis, right? We only have, granted that the field of phenomenology, as I was telling you guys before, looks to all behavior and signs in a much more broad way. But when it comes to diagnostic criteria, the complexity of it makes prohibitive to take everything into account. So DSM is, in a sense, and it started as such, a research guideline. So we could know that people in Europe were researching the same disorder than the people in the United States when they call major depressive disorder, right? So the idea was to have common criteria. The problem with the criteria, the way we use, is that they're it's a highly confirmatory procedure. So let me give you an example about the overlap between disorders. So we have here low mood, anxiety, poor appetite, auditory hallucinations, lack of interest in pain. And with the same group of disorders, If you take away the auditory hallucinations, you have just low mood, anxiety, poor appetite, lack of interest in pain. Now you have a syndrome, and that will be a major depressive disorder. Now, anxiety and pain are the symptoms more frequently related to depressed mood. The problem is they didn't make the cut for DSM because DSM tries to be exclusive, right? As opposed to put things that are common to many other disorders as well. Low mood, anxiety, and poor appetite. That could be an anxiety syndrome because, you know, people with GAD frequently feel sad even though they don't have necessarily anhedonia or sleep disturbances or disturbances of energy and motivation. Energy they should have because it's one of the, you know, tiredness is one of the symptoms of GAD. Lack of interest in auditory hallucinations. Lack of interest in this case would be part of the negative symptoms of schizophrenia with auditory hallucination, right? So now we're talking about schizophrenia. If we take all of them together, low mood, anxiety, poor appetite, pain, lack of interest, auditory hallucinations, we're actually talking about MDD with psychotic features, and we're still talking about the same group of these symptoms. If we take auditory hallucinations, lack of interest, and anxiety, now we're talking about probably schizophrenia or psychosis with paranoia. You know, it's easy to see how paranoid people feel very anxious. And if you have just anxiety and pain, or anxiety and poor appetite associated with pain, we may be talking about a chronic pain syndrome. So that is the challenge. The fact that we have sort of, according to the DSM, we have this limited constellation of symptoms, and we have to group them like clusters, right? We have to typify the patient according to each one of those groups. And because the overlap between the disorders is so big, we necessarily have to come to terms with the concept of positive and negative predictive power. So if you take, for example, a patient complaining of impaired attention, you're going to have that according to symptoms base rate, which is a publication that I would encourage anyone to read. We have in 4 different data collections, ADHD people complaining, about 50% of ADHD patients complaining of inattention, while 90% of patients complain with inattention when they have generalized anxiety disorder. Now, how does positive predictive value works? So if you find someone out there that has inattention, what is the probability that that is ADHD versus GAD? And not having inattention, does that rule out any of those disorders? So that is the concept of positive and negative predictive value. The presence of a symptom, what's the probability of a disorder given the presence of a symptom, and what is the probability of not having the disorder or excluding it given the absence of the symptom? The way we handle this thing